two beautiful countries in the world, India and Australia. This is eCritCare Podcast about evidence-based critical care medicine, helping you to save lives. Here are thoughts on controversies in critical care. And now, here are your hosts, Dr. Swapnil Pawar from Sydney and Dr. Jose Checo from India.
Welcome to eCritCare Podcast. This is our episode number 97. And today I'm joined by my co-host, Dr. Jose Checo. So welcome, Dr. Checo.
Thanks, Swapnil. Nice to meet you again.
Indeed. The weather in Sydney is a bit challenging at the moment, but glad to be here. And today we have decided to do another landmark trial, which has been recently published in New England Journal of Medicine, and that is Classic Trial. So I guess just the context to the whole controversy around the use of intravenous fluids in intensive care unit. We do use intravenous fluid in intensive care unit for resuscitation of patients with septic shock, and subsequently many patients receive intravenous fluids for various reasons, for as a maintenance fluid, as a carrier fluid for different drugs. And sometimes if the patients are still hypotensive in intensive care, they receive boluses of intravenous fluids to maintain the MAP above 60 to 65 or to maintain the urine output of more than 0.5 mils per kilogram per hour. Now, the whole controversy around this fluid has began after the FEAST trial, which was published almost a decade ago, which was the fluid expansion as supportive therapy conducted by Kathy Maitland and her colleagues in kids in Africa. Now, that trial showed the higher survival with the use of more fluid restrictive approach than with a standard approach to use IV fluid therapy among the children with severe infections. Now, there has been subsequently attempts and trials amongst adult population, and a more recent systematic review which examined the restrictive or active fluid removal approaches with the use of diuretics or renal replacement therapy in critically ill children and adults. And in that review, they kind of looked at 11 randomized controlled trials involving total of 2,051 patients. And in this, the restrictive fluids or active fluid removal approach was associated with more ventilator-free days and a shorter intensive care unit stays compared to liberal fluid approach or standard care. However, there was no mortality benefit. And I guess that has led to this controversy that whether we still practice this restrictive fluid approach in patients in intensive care who are admitted after the diagnosis of septic shock. Now, what happens in the intensive care unit, most of the time patients do receive 2 to 3 liters of fluid boluses in emergency department, and then they continue to receive resuscitation sometimes longer if there is no bed available, or sometimes there's a delay in getting admission to intensive care unit. And over the period of time during their admission in intensive care, patients develop a lot of positive fluid balance, which we call it as fluid creep. So I guess this trial has trying to determine whether the restrictive approach is indeed beneficial compared to liberal fluid approach in patients with septic shock. So Dr. Checo, can you please walk us through the methodology and the results of the trial, please?
Yeah, the Classic trial was a multicentric randomized controlled trial carried out in 31 ICUs in Denmark, Norway, Sweden, Switzerland, Italy, the Czech Republic, the United Kingdom, and Belgium. And the study was conducted over a 3-year period between November of 2018 to November of 2021. They included patients with septic shock with suspected or confirmed infection, plasma lactate level of more than 2 millimoles per liter. Patients were on a vasopressor or inotrope infusion, a minimum of 1 liter of intravenous fluids administered in the 24 hours prior to screening, and the shock was going on for at least 12 hours. They excluded patients who had life-threatening hemorrhage. Of course, that's a completely different scenario. Burns with more than 10% of body surface area involvement, and they excluded pregnant patients as well. Randomization was carried out in a 1-to-1 ratio, and patients were randomized to receive a restrictive compared to a standard intravenous fluid resuscitation strategy. Randomization was in permuted blocks of 6 or 8, was stratified according to trial site, and depended on the presence of a metastatic or hematologic malignancy. In the restrictive arm, intravenous fluid boluses of 250 to 500 mils of isotonic crystalloid was administered if any of these criteria were met, including a lactate level of more than 4 millimoles per liter, mean arterial pressure of less than 50 millimeters mercury with vasopressor or inotrope infusion, presence of mottling above the knee, urine output of less than 0.1 mil per kilogram in the first 2 hours of randomization. If intravenous fluids were required to replace fluid losses, that is, of course, given. And for correction of dehydration or electrolyte abnormalities, a daily fluid intake of 1 liter was targeted, including fluids associated with the administration of medication and nutrition, if enteral nutrition was not possible. In the standard therapy arm, intravenous fluids were administered according to the 2016 Surviving Sepsis Guidelines. As long as there was hemodynamic improvement, they would continue to administer intravenous fluids. And of course, it was also given to replace losses, correction of dehydration, electrolyte abnormalities, and as maintenance fluid in ICUs with a protocol that had a recommendation to do so. There was no upper limit on the volume of fluid administered. And common management included fluid administration based on recommendations regarding type of fluid, be it isotonic crystalloid. Most of these patients were given plasmolite or Ringer's lactate solution. Co-interventions included antibiotic therapy, source control, norepinephrine as vasopressor, and renal replacement therapy as appropriate. And the assigned type of care was continued until discharge from ICU for a maximum duration of 90 days. The rest of the management was based on clinician judgment. How did they calculate the sample size? The primary outcome was the 90-day mortality. They assumed 45% baseline mortality based on previous studies, and they assumed a 7% difference in the 90-day mortality and a 15% relative risk reduction. For 80% power and a two-sided alpha of 0.05, they calculated a sample size of 1,554 patients. So according to this calculation, they screened 2,223 patients, of whom 1,554 underwent randomization. And in the final analysis, there were 764 patients in the restrictive group and 781 patients in the standard fluid therapy group. Among the baseline characteristics, the source of infection was gastrointestinal, mainly in both groups, 36.8% in the restrictive strategy arm and 38.3% in the standard strategy arm. The second most common source was lung. Urosepsis was the third most common source. 52.6% of patients in the restrictive strategy arm and 48.6% of patients in the standard strategy arm received invasive ventilator support. The median lactate levels were 3.8 and 3.9 millimoles per liter, respectively. So among the findings, the median total volume of IV fluids administered in the ICU, excluding the medication fluid and nutrition, was 1,798 mils in the restrictive group versus 3,811 mils in the standard therapy arm. And the median cumulative volume, including all fluids, during the whole of the study period was 10,433 mils versus 12,747 mils. So the primary outcome was the mortality at 90 days. The 90-day mortality was 42.3% in the restrictive fluid group and 42.1% in the standard fluid group. The difference was not statistically significant. Among the secondary outcomes, they looked at serious adverse events, including cerebral ischemia, myocardial ischemia, intestinal ischemia, limb ischemia, and the incidence of severe acute kidney injury. These were not significantly different between the restrictive fluid group and the standard fluid group. The number of days alive and without life support was also not different between the two groups, 77 days in both the groups, and the interquartile range was 1 to 87, both the groups. So almost identical in both the groups. Similarly, the number of days alive and out of the hospital was also not different between the two groups. So they specifically looked at the duration of invasive mechanical ventilation. The median duration of the number of median days free of invasive mechanical ventilation was 80 days in both the groups, with an interquartile range of 3 to 90 in the restrictive arm and 4 to 90 in the standard arm. So the duration of ventilation-free days was also not different between the two groups. The authors also performed a subgroup analysis of the primary outcome, that's the 90-day mortality, in predefined subgroups of patients, which included patients with or without respiratory support, patients with or without acute kidney injury, lactate levels of 4 or less, body weight of 76 kilograms or more, and receipt of intravenous fluids prior to randomization of 30 mils per kilogram or more. So among these subgroups of patients, again, there was no difference between the two groups. So to summarize the findings, the authors found that there was no difference between a restrictive compared to a standard strategy of fluid administration in terms of the 90-day mortality, which is the primary outcome. The secondary outcomes included serious adverse events, including cerebral, myocardial, intestinal, and limb ischemia, and severe acute kidney injury, which was not different between the two groups. And the duration of time on the ventilator was also not different between the two groups, as was the case with days alive without life support and days alive and out of hospital. By life support, they meant the requirement for invasive ventilation, requirement for vasopressors or inotropes, or the requirement for renal replacement therapy. So on the final analysis, they couldn't find any difference in the 90-day mortality, nor in the incidence of organ dysfunction, nor in the number of days on ventilation or ICU or in the hospital.
Thanks, Dr. Checker. So I guess this trial is quite interesting. And again, as I mentioned, landmark trial on this topic. Just going back to some of the tables, and particularly the first one, which was the characteristic of patients at the baseline. Median age group, as you mentioned, was around 70, which is slightly older population than what you expect to be involved in the randomized control trial. So I guess that's the first thing to mention. Obviously, there was no difference between the two groups. And the second important thing was source of ICU admission and source of infection. So there was majority of the admissions came from emergency and hospital ward settings, which is what we normally see. So quite pragmatic trial. And the focus of infection was actually GI tract in majority of the patients in both groups. Now, only 30% of the patients in each group received systemic corticosteroids. And it was interesting to see that only around 50% of patients in each group received a respiratory support. So on one side, you can argue that these patients were relatively sick. Now, the median volume of fluid received in 24 hours prior to randomization in both groups was around 3 liters. And again, that is what we normally see in the clinical practice, that before they arrive to ICU, most of the patients have received already around that 3 liters figure mark. So it's a very pragmatic trial in terms of what we normally see in our ICUs. So very similar data around those cohort of patients. The second important thing to look at is around how much fluid these patients received. And I guess after first day in each group, patients received around 2.3 liters and 3.1 liter fluid, which was not much difference between the two groups. And by the end of the 5 days, interestingly, the standard fluid therapy patients received 11 liters of fluid, while restrictive fluid received 9 liters of fluid. So it's a still quite significant amount of fluid that patients receive during the first 5 days of admission into intensive care unit. However, interestingly, the cumulative fluid balance was again not high as I was expecting. So 1.1 liter in the restrictive group at 1 day and 1.6 liters in standard fluid group, and around 2.2 liters in restrictive fluid group and 3.1 liter in liberal arm at the end of 5 days. So overall 2 to 3 liters positive fluid balance by the end of 5 days in both groups, which is what we normally see. But sometimes it can be more depending upon the nature of the patients and nature of the ICU. There are kind of baseline facts which are, I guess, interesting. Now, the real question is, because this trial has not shown any mortality difference between the two groups, the question is which strategy is better. Now, some people might argue that that means we can just continue to use liberal fluid strategy because it doesn't cause any difference in the mortality. And is that a conclusion that should we go with? And I guess before we kind of come to any conclusion, the key things to understand that this trial has tested more on the management strategy or compared management strategy, whether one is better or other, versus testing the one intervention or one drug particularly is better than other. Because a challenge with this comparing this management strategy between the two groups, and if there is no difference between the two strategies, which is the standard of care versus the restrictive fluid strategy, then obviously you're not going to see the difference in overall outcome. And that's exactly what probably happened in this trial here, because there was not much difference in the amount of fluid that patient received in the liberal fluid versus the restrictive fluid. So what does it mean is over the period of time, we have got better with our fluid administration practices, and we have become much more conservative in administrating fluids to our patients. So I guess that's the first point to note, that probably there is no much difference in what we normally do in usual care compared to restrictive fluid strategy. The second important thing in terms of the sample size calculation, authors were a bit ambitious to expect the mortality difference of around 7%, which is the absolute difference, or 15% relative reduction in mortality, which is, again, probably made this trial slightly underpowered. And also they went for 80% power rather than 90% power. Now, they assumed the baseline mortality will be around 45% in this cohort of patients, and it was found to be 42%. So the benchmark or the ballpark figure was pretty accurate, but obviously aiming for 7% absolute risk reduction was quite ambitious, I guess. The other important thing to note is the external validity of this trial. So this trial was particularly conducted in Scandinavian countries. So I guess the fluid administration practices might not be similar in all parts of the world, and that there might be differences in how we practice our fluid administration in different ICUs in different continents. So I guess the external validity will be questionable. Last one is compared to the reverse trial, which was published in 2001, and even after the 4 iterations of surviving sepsis guidelines, overall, we have changed our practices over the period of time. And overall, we have gotten better with our overall fluid administration practices. So there has been that component or element of change in practice over the period of time in patients with septic shock. So I guess how much that factor has played a role in affecting the result trial is also quite interesting to think about. So I guess even though the overall difference in the mortality was not shown, one thing to kind of take away from this trial is a restrictive fluid approach or fluid strategy does not harm the patient. And I think that's why to then waste more fluid or unnecessarily give fluids to our patients. And again, coming back to the cost-effective analysis, that extra 2 to 3 liters of fluid at the end of 5 days can be quite cost-expensive exercise. So that's kind of my take on this trial. What's your take on this trial, Dr. Shaker?
You are right, Swapnil. The difference between the two arms in terms of the volume of fluid administered and also the cumulative balance by day 5 was not very much different, although it was numerically different. It was not that kind of vastly different that would suggest a major difference in the strategy of fluid administration between the two arms. In fact, the difference in the cumulative balance at the end of 5 days was approximately 800 mils between the two arms, which is not very much really. So as you rightly mentioned, the strategy of fluid administration, even in the standard group in this particular trial, was more or less restricted compared to the strategy one used to follow in the past, particularly with the previous versions of the surviving sepsis guidelines, which suggested normalization of lactate levels and resuscitate until you normalize lactate levels, which is no longer recommended anyway. So the practice over time has changed. And even with standard care, physicians are wary of excess fluid administration, and they tend to restrict themselves. And that's what probably we saw in this study as well, in that the volume of fluid administered was not as high as it used to be in the past era. One of the other things, of course, the duration of time on ventilation was not different, but it was included as part of a secondary outcome in terms of the organ support-free days, which included time on ventilation, time on vasopressor, as well as time on requiring renal replacement therapy. So maybe they could have included the duration of time, the duration, ventilator-free duration as one of the outcomes, as they had done previously with similar trials that may have been perhaps been meaningful as well. And I was also curious to know about the PF ratio, which they hadn't provided, as to whether a strategy of restrictive fluid administration would result in better PF ratios and perhaps easier venability. But that data is not available. Anyway, I think we haven't heard the last word yet on the strategy of fluid resuscitation. I'm sure there will be many more studies that will probably need to address this question. And because of a large number of protocol violations in both the groups, in fact, some 15% of patients in the restrictive arm and more than 20% of patients in the standard arm had fluid out of protocol and had violations in different ways. So that also affects the final results of this study. So overall, it adds strength to the existing knowledge in terms of adopting a restrictive strategy. And the bottom line, of course, is that even with the restrictive strategy, there is certainly no evidence of harm and possible benefit, which this study couldn't show because the difference was not really very much different between the two groups.
Yeah, that's correct. And I guess, as I mentioned, still this trial remains one of the landmark trials on this topic because it has raised the new important questions, which has challenged our conventional wisdom regarding the management of shock. Because till this point in time, we still don't know how much fluid we should give. And I just mentioned, we still use arbitrary targets, and some of the targets that we discussed in our last episode of podcast in patients with septic shock. What are the targets, what we should go with? And at the moment, it's more of an art than actual science, and how people practice their fluid resuscitation at the bedside. And even we don't know if we end up in giving more fluid, when should we start removing the fluid, or should we even attempt to do that? So there are a lot of uncertainties still regarding the physiologic thresholds, targets, when we should stop giving fluids, when what is the ideal time to initiate vasoactive drugs, even though we know that we should start vasoactive drugs early, but how early is not kind of sure. And also, I guess, when we should start actively removing the fluid. So there are a few unanswered questions which have been highlighted by this trial. But again, kudos to authors for conducting another very robust, well-designed randomized controlled trial on this topic, which has also given more information on the baseline data of septic shock. And again, one of the main takeaway is septic shock is still an important problem that we face in day-to-day life, with a 45% mortality, which is still quite significant. So I guess a lot of efforts still should be directed towards addressing the management of septic shock, because if we reduce the mortality of patients with septic shock, then obviously we can achieve the meaningful differences to many lives. So I guess that's the kind of key take-home message for me. So thanks, Dr. Chacko, for your time. We'll be back in week's time with another episode. So till then, goodbye and have a nice time.
Thanks, Swapnil. Thanks, everyone, for listening. Goodbye until next time.
Thanks for listening to eCritCare Podcast. If you like what you just heard, we hope you'll pass along our web address, www.critcareedu.com.au, to your friends and colleagues. And please leave us a positive review on iTunes. Be sure to check out our archive section on our website for previous podcasts. Check us out on Facebook at Critical Care Education. Join us next time for another edition of eCritCare Podcast.